Sir, I didn't understand the question.
Hello, am I audible?
Yes, you're audible.
Yeah. Am I, that after the
Your sound is just breaking.
Your voice is chopping up, Dr. Khan. Can you please send your question in the chat so she can look at it?
Okay, fine. Dipti, you can go ahead for the next speaker.
Okay.
Yeah, Amulya, a very good presentation. I just wanted to ask a couple of questions. So this was a post-renal diabetic patient. So how were the sugars managed in the post-op period? And what were the biochemical urea and creatine values in the post-op? And it was very good to see that you had started a ONS supplement along with a liquid diet in day 1. That's very good. But for a renal transplant, you need not wait for a whole day to start on the diet. You can immediately first, when it is finished in the first 1 or 2 feeds, we give the liquid diet, and then we move on to the soft solid or the normal diet for the patient. So I just wanted to know about the sugars and the urea creatine values post-op.
Post-op. My post-transplant is transplant investigation. Here the urea on the 6th of February, it was 59.3. There was a slightly high itself in the diet. That is on 8th, it was 77.3. And 10th of February, it was 77.6. And again by 12th, it slightly decreased to 67. And creatine level, once after the surgery, it was 4.93, and it just went down to 3.14. And it's by the following days, that is by 10th, it reached 1.5, and by 12th, it reached 1.26. 1.26. And albumin level also, it was only same. That is by the first day after the surgery, that is, it was 3.29. She was hypoalbuminemic. And on the 8th day, it was still she just followed fall in the hypoalbuminic state itself. And 10th, by 10 of February, it was 2.94. That was a severe decrease in the albumin levels. And by 12th, it slightly increased to 3.04. And for this protein part, while giving ONS, it is very important. That is recovery phase. No, it is 0 to 6 days. The catabolism is severely high. So our intention is not only to monitor the kidney, and there should not be muscle loss. So we have to give an aggressive protein intake for the patient.
Okay, and the sugars were not high?
Sugars are not high. If may I check? The sugar levels were not presented, I think. Sugar levels were normal only, ma'am. Normal in sense it was slightly elevated than 146, 147, 156, that level. HbA1c was 5.7. That means slightly pre-diabetic only. But we followed a diabetic diet.
Okay, the HB also was normal because it's a renal case.
HB was 9.3. There was a slightly post-surgery, we did a blood transfusion, and she got about 10. And post-surgery, it was 9.3. By the 12th day of discharge, we give high protein diet. So.
Yeah, that's right. But when the hemoglobin levels are low, we do not consider the HbA1c, because HbA1c is the sugars which is for the 3 months. But here the HB itself is low, so we can't consider the HbA1c. So we would have to monitor the fasting and the PP, because they'll be on steroids and coming back with high sugars. So educating them on the complex carbohydrates is also very important.
Yeah.
Okay. Yeah. Otherwise, a good presentation. Thank you.
Yeah. Thank you, ma'am.
Okay. So we have our next presenter. Radha, are you ready?
Yeah, yes, ma'am.
Okay, great. Sai, can you please share her presentation? And your time starts now. You have about 12
Yeah,
minutes to wrap up your presentation.
done, ma'am. Yeah. A very good
Thank
evening
you.
to one and all. Myself, Radha Sista, Senior Clinical Dietitian from Continental Hospitals, Hyderabad, is here to present a case study titled case study presentation on diabetic ketoacidosis. So, as we all know, that DKA is one of the life-threatening emergency complications of diabetes, where a severe lack of insulin causes the body to break down the fats, and this results into the energy production. So, during this process, we see a lot of ketone bodies which are being released into the bloodstream. And in this process, the sugar levels are usually seen above 250 mg per dl. And we also see severe dehydration and metabolic acidosis. Uh, in this case study presentation, we have received a female of 53 years old to our emergency, wherein she was of the following anthropometrics of 155 centimeters height, 62 kgs, and BMI of 25.8 kgs per meter square. Her ideal body weight was calculated as 53. Can we go to the other slide, please? At the time of admission to ER, she presented with seizures-like activity on 23rd October 2025 in the early hours, wherein she had this involvement of bilateral upper limbs, and there was no tongue bite, frothing, or uprolling of eyes, which was reported. On arrival at the ER, the GRBS was checked, and it was showing greater than 800 mg per DL, which was not detectable with the GRBS monitor, neither in the lab. Prior to this incident, she reported a history of fever and cough, which was persistent for the last 2 weeks, and decreased appetite, decreased responsiveness, as well as generalized weakness for the past 2 weeks. Current, she was also a known case of hypertensive and was on medication. And the final medical diagnosis at the time of discharge was stated as bilateral pyelonephritis with anemia, LRTI, uterine prolapse, AKI stage 1, which was resolved, and DKA and de novo DM. So the most important or the common causes of DKA are infection, de novo DM, non-adherence to treatment or certain medications, and acute medical stress. So can we move to the other slide, please? So it's not like DKA is fatal, but if right time, right treatment, and if it is kept unnoticed, definitely that causes fatal. So the following are the clinical lab parameters, wherein the patient was anemic, as reported earlier. Patient had hyperkalemia and hypernatremia in the initials, which was resolved later on, and definitely AKI in the initials, and that also got resolved at the later end. Can we move to the other slide, please? Yeah. In the initial, when the GRBS monitoring was done on the day of admission, till 9 a.m., the sugars weren't able to be read on the monitors. So at 9 a.m., the sugar reported as 585 mg per DL, and the patient was on continuous high infusions as recommended by the endocrinologist and the diabetologist. So during her hospital stay, she was on insulin from the day of admission up till the day of discharge. And later, at the time of discharge, the patient was advised on the OHA. Can we move to the other slide, please? At the time of admission, the HbA1c was noted as 17.6%. 1 month later, it came to 10.4, and 2 months after, from the time of admission, it was 5.9. Can we move to the other slide? So during her course of admission, she underwent other investigations apart from her lab parameters such as CT, abdomen, and pelvis, which showed bilateral pyelonephritis, large cystosol, and complete prolapse of the uterus. Her culture report also turned out to be positive for Klebsiella pneumonia in both blood and urine, for which the antibiotics were initiated along with her antacids and the other medications which was advised by the critical care team. Can we move to the other slide? So coming to the nutritional assessment and intervention, since the patient was having fever and a cough in the initial days, prior to the admission for 2 weeks, her appetite went very low, and she was on buttermilk and curd rice intake only, which was giving her about approximately 500 kilocalories and 7 grams of protein, and that was her 24-hour recall. Nutrition assessment showed as SDA was done, and she was falling in the category of normal. Initially, the patient was on Ryle's tube feeding, and followed by the patient was on oral liquids and oral diabetic soft diet, and then later she got discharged. Can we move to the other slide? So the nutritional diagnosis, that is the PESS statement, stands as inadequate oral intake and altered nutritional related laboratory values related to acute metabolic stress and lack of diabetes knowledge that has led to, and we have evidenced, de novo DM, poor intake, less than 500 kilocalories per day, hyperglycemia, and reduced functional capacity. So the short-term goals were established as to initiate the oral diet at the earliest, because initially she was on the dial strip feeding, followed by to provide a low carbohydrate, high fiber diet, and to monitor GRBs thoroughly. The long-term goals were laid as to prevent DKA, to prevent muscle loss, to provide adequate micro and macronutrients. Can we go to the other slide? So the calories were estimated as 25 kilocalories per kg ideal body weight, which rounds to 1590 kilocalories per day, and protein as 1.5 grams per kg ideal body weight, coming to 80 grams per day. And carbohydrate is 20 grams per day, 200 grams per day. Here we have also checked for the micronutrient support, such as iron and vitamin B12, because we wanted her anemia to be recovered. There, hyperkalemia, hypernatremia was there. So we wanted to make sure that in terms of diet, she was getting a proper, which was not having excessive sodium or potassium from the diet, as well as calcium and zinc and selenium also, because zinc deficiencies can exacerbate insulin resistance and impair glycemic control. Also, it has a role of antioxidant. So coming to selenium, since it acts as a component of selenoprotein, example like glutathione peroxidase, which has a insulin sensitivity and on the glucose metabolism. So that is the reason these were into consideration. Fluid was 3 to 4 liters per day. We wanted to do a fluid resuscitation to fill the HAGMA gap. HAGMA stands for high anion gap metabolic acidosis, which means a life-threatening acid-base disorder, which is defined by a serum anion gap greater than 12 milliequivalents per liter, which results from the accumulation of unmeasured acids. So this is usually found out from the ABG values. That's the reason, and the fluid resuscitation is very, very important. So this HAGMA gap is also caused by the diabetic ketoacidosis and lactate acidosis, or renal failure or toxic ingestion. Can we move to the other slide, please? Yeah. So on the day one of the enteral nutrition, we could establish 15% of the calories and proteins from the derived RDA. On the day two, 50% was achievable. Followed by day four, there was a plan of transit from RT feeds to the oral diet, but that couldn't be established because the patient was little drowsy. Hence, on the 27th, we were able to transit the patient from RT feeds to oral liquids. And on 28th, the patient was tolerating diabetic soft diet along with ONS, and patient was advised to take the liquids also in view of fluid resuscitation. So overall, on an average, 876 kilocalories were provided and 32 grams was delivered of protein. The percentage deficit of energy was 50, and the percentage deficit of protein on total average was 60. Can we move to the other slide, please? So at the time of admission, the patient was 60, but at the time of discharge, the patient was at the time of admission, the patient was 62, and at discharge, she was 60, wherein 2 kgs of weight loss we have observed, and that could be because of the fluid shifts also. Hand grip strength was very poor, which was estimated using the hand grip dynamometer. Intake was improving, but still it was not as adequate as it was supposed to be. Evaluating against goals where targets were met and any adjustments were done. That is the improved glycemic control enabling the transition from insulin to OHA could be happened, and weight stabilization achieved with minimal lean mass compromise. Next slide, please. This lean mass measurement was possible only through BCA, and I'll be explaining it in the next slide. So this was her discharge diet plan, wherein moderate calories with high protein and high fiber diet was suggested. Can we go to the other slide? So recommendations were avoid consumption of high fatty foods and outside foods, avoid consumption of larger meals at once, and simple sugars were restricted. We have educated her to include fiber and whole cereals and pulses in the diet. Since she was not in a comfortable state of health where she could walk for a longer duration of time, so we have asked her to go for a light walk for 20 minutes every day, or possibly like 10 minutes after each major meal. Next slide, please. So she has come up for the follow-up, and she has also sent us her GRBS data every day. So the first 3 days data have put up here of GRBS values. Later, the discharge after 1 week, she was here at our OPD where the BCA was conducted. We wanted to do this BCA when she was in house, but the family was restraining the BCA to be done. So at the time of first follow-up, proteins was 7.1 kgs and body fat was 18.2 kgs and fat-free mass was 37.8. So this showed she had a normal skeletal mass in the fat. There was no excessive or there was no depletion. Can we move to the other slide, please? Yeah, so also I wanted to add up that after her first follow-up at OPD, the second follow-up was made during her surgical stay in the hospital, where she has come up for the total laparoscopic hysterectomy. At the time also, the patient was taking diabetic normal diet along with the ONS. So this patient and the attenders were so happy and they were quite comfortable to give the regular follow-ups, and still they are in touch with us and the patient is doing good. They have happily walked out of the hospital with HbA1c coming to 5.2%, 5.9%. So the learning from this case study was to prevent weight loss, which we were able to achieve it, controlling the sugars after she was off the insulin, which was again a green flag for us. Also timely follow-up and the patient's interest in adhering to the diet and reporting back to the clinical dietitian was also win-win for us. And early nutrition intervention helped to prevent excessive muscle loss during DKA recovery. And the next slide, please. So a thorough follow-up within this emergency metabolic state of diabetic ketoacidosis has made a significant nutritional compromise, and early and structured nutrition intervention has helped to focus on the adequate nutritional goals, and we have achieved it. Also, this nutritional intervention has helped a crucial role in metabolic stabilization and prevention of muscle loss and recovery in these patients, which was proved by the BCA. This case also emphasizes the importance of timely nutrition screening, continuous monitoring, and patient family education in preventing recurrent decay. So, especially in such newly diagnosed diabetes, a multidisciplinary approach with active involvement of the clinical dietitians is essential for improving both short-term outcomes and long-term metabolic control. The next slide, please. So nutrition care is not supportive but therapeutic in the management of prevention of decay. Thank you so much. Thanks to Yuri and Pulse for this opportunity.
Radha, that's a very thorough presentation. Good job.
Thank you so much.
Yeah. So now we are open for any questions from jury members. In the meantime, our next presenter is Ms. Christina. If you can please get ready, that would be great. Any questions for Radha and the jury members?
This is Dr. Joditra again. Yeah, Radha, it was a very
Yeah, hi,
excellent
sir.
presentation, and I kept on auscultating for each and
Thank you,
every
sir.
word that you have described thoroughly about the diabetic ketoacidosis and also the different per se about this glucose monitoring in detail. But I would like to one thing that you have mentioned the DKA. So importance of the keto diet, is it a fallacy or it is so important for maintaining for the DKA for the patients for managing with this seizure and the diabetes? And simultaneously, is there any kind of role of the oral nutrition supplementations, like any kind of ketogenic supplementation, which is actually necessary on top of therapeutic treatment that you have mentioned with the conventional dietary management?
Okay, sir. This lady presented with seizures, but the seizures was not involving, or this was not because of the neurological conditions. This was purely because of the diabetic associated due to the metabolic acidosis only. This seizures had happened. In this case, ketogenic diet, I don't think so. It is going to be going to lay down a lot of importance, but definitely high protein, wherein high fiber diet will definitely help in recovering. Talking about ketogenic supplements, I mean, till date, or when we take seek the updates from Aspen or Aspen, we see that it is more for the scissors involving the neurological conditions. But later on, till date, also this patient doesn't follow up with us, and she never developed again scissors. To think about from that perspective also. So I mean, to conclude this, I can say that while for particularly this case, maybe the diabetic diet only suits better, and that is the reason we had to take a step of choosing the supplement which was diabetic friendly.
Very
Okay.
good presentation, Radha.
Thank you so
It
much,
was
Rashmi.
very interesting also. And I just wanted to ask two questions. So you
Yeah.
had mentioned low carbohydrate. So how much of carbohydrate are you going to give for in this kind of case?
Ma'am, we have taken 30% of the total kilocalories.
30% of the total kilocalories. So
Sorry,
how many grams of
sorry.
carbohydrate did you
It is
get?
50%, ma'am. 50% of the total kilocalories, where it is coming 200.
200. So in the tube feed,
Yes,
you
ma'am.
have calculated that way?
Yes, ma'am. We have calculated in that way only.
Okay. But
We have a
because
format wherein we have
ah,
this calories and carbohydrate also needs to be
mm,
given to our
mm.
endocrinologist. Particularly, this is a
Mm-hmm.
DKA case. So
Yeah,
that is the
yeah.
reason we have made sure that it is coming to a lower side only, and that has been mentioned in our enteral feeding note as well.
Yeah, because if you say 50% of the carbohydrates are coming from the enteral feeds, then it is a normal one, because low carbohydrate means it's a 50 gram of carbohydrate which we give. So actually we
Okay.
cannot say this is a low carbohydrate. We can say this is as per
No.
the diabetic thing that we
Okay.
have calculated. And was there so you had mentioned also high fiber. So in an
Yes,
enteral
ma'am.
feed, did you add any fiber
In
supplements?
no, ma'am, not in the enteral feed, but later on in the oral diet only we have considered.
Okay. And you had also mentioned micronutrients were also replenished. So
Yes,
which
ma'am.
micronutrient did you think would have made a massive impact in case of diabetes?
Ma'am, selenium and zinc only, to be honest. So that is the
Yeah.
reason I have put up here also, and we have asked her to take the MVI and during her hospital stay, and followed by the supplements which were recommended by the doctor.
So multivitamins were given
Yes,
during her
ma'am.
stay.
Yes, ma'am.
So
Yes,
it
ma'am. It
did
was given.
contain the selenium. Usually
Yes, ma'am.
multivitamins do
Yes,
not
ma'am.
have.
No,
It
it
was
was
there.
given, ma'am. Yes, ma'am. It was there.
Okay. Yeah.
Since I cannot disclose the brand, but otherwise it was there.
Yeah.
Yeah.
Good one, Radha.
Thank you,
We
ma'am.
will move on to our next presenter. Christina, are you ready?
Yes, ma'am.
Okay. All right. You have 12 minutes. Please stick to your time. And your time starts now. Go ahead.
Good afternoon, everyone. Am I audible? Hello?
Yes, you are.
Okay.
You're
A little
audible.
louder,
Go ahead.
Christina.
Okay, ma'am. Good afternoon, jury members. I'm here to take my case presentation, and the topic for my case presentation is CAD and STEMI. Next slide. Next slide. So, as we all know, CAD is actually a progressive atherosclerotic disorder, which is caused due to reduced blood supply, and it remains one of the leading cause of global mortality and morbidity rates across the world. And now, as for my topic, CAD and STEMI, let's see what is STEMI. It's also a kind of heart attack, an acute coronary syndrome that occurs due to partial coronary artery blockage. And that mainly happens because of plaque rupture or like erosion with thrombosis. And the main distinction between the NSTEMI and the STEMI case is that in NSTEMI patient, there will be an ST elevation shown on the ECG report. But on the other hand, in STEMI case, the ST elevation cannot be depicted on the ECG graph. Now, what could be the leading risk factors and etiological contributors? They are mostly certain comorbidities like SG and DLP, increased levels of LDL cholesterols in the blood, CKD, and then hypothyroidism, T2DM, all of that can contribute and increase the cardiovascular risk even more. So, the myocardial damage in long-standing CAD and STEMI will lead to reduced left systolic dysfunction, reduced left ventricular pumping, which will in turn increase the filling pressures in the alveoli of the lungs. And this can ultimately lead to conditions like CCF. And upon that, complications such as pulmonary edema can occur. So from that, we can say that pulmonary edema is not actually the primary diagnosis in itself. It's just the manifestation or a complication, we say. So now the clinical symptoms which can occur with CAD and STEMI are like chest pain, discomfort, and then dyspnea, shortness of breath, and excessive sweating, diaphoresis, nausea, vomiting, fatigue. All of this can impair the cardiac function and promote pulmonary congestion. Next slide. Now, moving on to the dietary guidelines and the nutrition relevance. As for the guidelines, the main factor is that you have to restrict sodium and fluid in order to control the pulmonary edema and to prevent cardiac workload. And it's advised you follow a healthy, heart-healthy diet, which include mostly heart-healthy fats, limit trans fats and saturated fats. And then you have to provide controlled carbs for glycemic stability. And protein is also kept at moderate level with regard to the CKD status of the patient. Now, as for a general rule in cardiac patients, we say encourage small meals, small frequent meals. And then, so these are the basic dietary guidelines to cardiac CAD and STEMI patients. Next slide. Now, looking at the patient profile, we see my patient is a 58-year-old female who was admitted to the CCU unit. And upon screening her nutritional risk, the tool SJ score was obtained to be B, which indicates that she was moderately malnourished. And upon calculating her anthropometric measurements, we found that her BMI was about 25 kg per meter square. That indicates that she is slightly on the borderline overweight category. And the IBW was calculated using Lemon's formula and was found to be 54 kg. Now, when you look at the medical history of the patient, we see that she has had a couple of past medical histories. That means she was a patient with a non-case of DM on insulin like for over 3 years, and she also had a history of CKD, but that was managed conservatively. She was a patient with CAD and also AWMI that actually evolved a couple of months before the recent admission at the hospital. And she has also had certain other comorbs like HNDLP and all. Now, with what complaints she presented to the hospital was that she had complaints of breathlessness and sweating, profuse sweating. And from that, she was diagnosed with bilateral pulmonary edema. No major procedures or surgeries she had underwent, just that she had underwent CAG, that angiogram and echocardiography. Next slide. Now, these are the drugs, medications prescribed to the patient. So here we can see that the TAP ecospirin AV, which is an antiplatelet statin compound. It's a cardiac medication for thrombosis prevention and to reduce the LDL cholesterol level. It has like a drug-nutrient interaction with excess intake of alcohol, which can like increase the levels, hypertension levels. So a low-fat diet is basically suggested. Similarly, for TAP sorbitrate, that's also a cardiac medication. Excess alcohol intake may impair the nutrient interaction. So it's suggested to reduce the alcohol, to like limit the alcohol usage. Then TAP cyanide IP is a BP medication to control the BP and also offers cardiorenal protection. The interaction is with grapefruit, so the juice of grapefruit juice has to be avoided. Then injection Lasix is a loop diuretic, mainly for fluid overload relieving properties, and it can have like potassium, magnesium low, so monitor electrolytes. And then TAP thyronome, it's a endocrine function a thyroid hormone replacement medication. So here there's not much of an interaction, but you have to take it in an empty stomach to avoid absorption interferences with calcium, iron and soy. And TAP acidose is an alkalizing agent. It's a renal correction medicine to prevent acidosis in CKD. It can like have potential sodium load, so it's advised to patients are advised to restrict sodium and fluid with the intake of this medication. And the other two are TAP ACI and Lonosaf, antibiotic medications only, and these are like to prevent infections. Not much of a food interaction is there, but you have to like not take heavy meals with these medications. Next slide. Now, looking into the biochemical report, we can see that urea and creatinine levels were on the higher side. It was completely deranged, but the sodium levels were relatively stable. The potassium levels showed mild hyperkalemia, and it can like indicates that there is cardiac strain over being hyperkalemic. And then the tropi test was done, and the BNP test showed elevation like up to 8,191. So these indicate that the patient has had severe cardiac strain with regard to the BNP test and all. Next slide. Now, this is the blood glucose level. Here we can see that I've taken the morning blood sugar levels in order to avoid the postprandial variability. And I've plotted a line graph showing the trend of the early morning blood glucose levels. Next slide. Okay. Now onto the input and output chart, we can see I've taken 3 days consecutive values, and upon the input and output values only, the doctor had prescribed fluid restriction for 1.2 liters per day was the restriction prescribed to the patient. And looking onto her lipid profile, we see her HDL levels were very much low. On the other hand, the triglyceride level was so much on the higher side. So her clinical examination revealed her vital signs were like stable, just that the SpO2 levels were okay, the BP levels were also okay, but the EF was very much on the lower side. It was just 25 to 30, indicating cardiac dysfunction. And also the A1C level was 7.9. That also remarks that the patient has had poor glycemic control over the last 3 months. And next slide. Now on to the MNT goals and objective. So the main goal
Christina,
is, yes, ma'am.
you have 2 more minutes.
Okay. The main goal is to reduce the cardiac workload and prevent fluid overload, and to delay progression of renal and cardiovascular complication. Mostly heart healthy diet is prescribed, and the 24-hour recall, we can say it was mostly inadequate in protein, and the best statement here is as follows: inadequate energy and protein intake related to increased metabolic stress and reduced oral intake secondary to CAD and STEMI with severe LV dysfunction, CCF CKD as evidenced by SGS score and suboptimal dietary intake. Next slide. So the diet prescribed to the patient was low protein, low fat, renal diabetic diet, and the calculation using modified RDA is as follow. The energy was obtained to be 1620. Carbs was obtained to be 60. I took 60% of the total calories, and it was found to be 240. The protein was kept 10%, restricted to 10% because of the CKD status. 1 gram that I obtained.
Dr. Remya, could you please?
Fat was 30% of the total calories I took, and I obtained 54 gram. Now the hospital recall, I took 3 days actual intake, and the average was calculated as herein. Next slide. Next slide. So this is the prescribed diet. Mostly complex carb was considered, and fiber sources was also added in the diet. Next slide. And from this, I obtained the carbohydrate, protein, fat, and everything. As carbohydrate was obtained to be 290, energy 1526, protein 54, and fat 32.54. Next slide. Now, upon comparison of the hospital diet with the prescribed diet, using modified RDA, I found out that the percentage deficit and excess showed that from the hospital diet, the carb, energy, and protein showed a deficit, while the fat showed a positive balance, like 223. And upon the prescribed diet, the energy and fat showed a deficit, while the carb and protein showed positive balance. Next slide. So as to conclude my case study, my patient, a 58-year-old female with CAD, complicated by NSTEMI, severe LV systolic dysfunction with a very low EF, and had CCF, presented with bilateral pulmonary edema. The condition was even more complicated with other comorbidities like DM, CKD, HT, and DLP, all of that, which in turn increased her atherosclerotic risk even more. And upon her nutritional assessment, her BMI 25 indicated a borderline overweight status, but that does not equal to the nutritional adequacy. She even then had a poor dietary intake due to her acute illness at that time. The patient 3-day actual intake indicates suboptimal nutritional consumption only, and she was prescribed a 1500 renal diabetic diet initially with a salt restriction of 2 grams per day and a fluid restriction of 1.2 liters per day. Later on, the diet was modified to soft diet upon her tolerance. And at the time of discharge, the patient was advised 1,500 kilocalorie renal diabetic normal diet. So from this, the outcome is that we can, what we can suggest is that you can provide a cardiac and a renal appropriate diet for patients with CAD and renal impairment. But keep in mind to provide moderate carbs, adequate protein, is essential for the recovery. So keep adequate protein, but within the renal limits. And restricted sodium and fluid is essential very much in order to support the recovery, then to prevent cardiac workload and further complication in the long run. Next slide. Thank you.
Thank you so much, Christine. That was a very good presentation and thorough. Any questions for Christina in the jury members?
Christina, this is Dr. Loritro. Yeah, it was. Hello, am I audible?
Yes, sir. Now it's audible.
Hello,
Yeah.
am I? Yeah. Yeah, so fine. This is a very nice presentation that you have chosen at least one case from the heart. Basically, you wanted to highlight about the left ventricular ejection fraction or heart failure with reduced ejection fraction, HF-ref patient, which was very particular, and you have shown already about ejection fraction. But these things is very important regarding the medications. I don't know who is the cardiologist over there, and he has given such kind of medications over there, which is actually one is a calcium channel blocker, but there is a
You're
missing of
breaking
the
up.
drug, which is actually treated with the heart failure. That is the ARNI, that is angiotensin receptor replacement inhibitor. So did you take such kind of any kind of sorry?
Could you like
Hello?
in the chat box?
Yeah.
Yeah,
So
your
did you
voice
see
was
any
very,
kind
very
of
chopped.
medication which is in covered with the sacubitril or valsartan, like antidotically for treated with the heart failure? I have not seen that particular drug is there. Maybe the renal problem where there is too high urea. Hello?
Since the urea
Hello?
levels will completely
Hello?
be reached. Am I audible?
Yeah. Yes, you
Yes,
are.
yes, you are audible. Yeah, completely deranged. This is number
Yes.
one. And so for the urea and the creatinine level, though the blood pressure was normal, I have not seen there any kind of hypotension. So did the doctor tried this particular patient for the SLADE or any kind of hemodialysis?
Actually, the patient has not underwent dialysis at the time of admission
Okay.
during the hospital stay. But when I encountered the patient to get more details, she told me that she had done one HT, but that was like long back, like for over a year before she got admitted in this admission. So in the current hospital stay, she has not underwent any kind of dialysis till now.
Okay. So the patient is on with this 25-30% ejection fraction. Neither there is any kind of ARNI drug, nor any kind of mineralocorticoid antagonist like MRA kind of drug, and patient the conventional therapy with the low protein diet and the cardio friendly diet. Okay, that's it from the your end. Anyway, thank you so much.
Yes, sir.
Thank you so much, Christina. Dr. Ramya, do you have a question? All right. We will now. No. Okay, go ahead. Dr. Ramya.
Christina, one question. What are the micronutrient management?
Micronutrient, regarding the micronutrient management, we have like monitored her electrolyte levels, sodium, potassium, even phosphorus was monitored. But with that, we have like counseled the patient regarding diet. In diet, the micronutrient levels to be considered, but not essentially. I put the electrolyte criteria in the diet plan, but we have just verbally counseled the patient regarding the micronutrient intake and all of that like that.
Okay.
A very good presentation, Christina. Because the ejection fraction was 25 to 30%. So how much was the salt and the fluid restriction followed for the patient?
The salt restriction was kept to 2 grams per day, and fluid restriction was prescribed by the doctor upon her input and output values. It was kept to 1.2 liters per day. In order to avoid the pulmonary, like progression of pulmonary edema even further. And she's also having CCF. So to avoid the congestion, cardiac pulmonary congestion and like that. So for that, the fluid restriction was kept to 1.2 liters per day. This includes restricting fluids from not just the hydration through water, but also through the water we take for cooking in the food they eat, medications, everything is included in that.
Okay, did you also look into the potassium because the potassium levels were also high?
Yeah, potassium levels at the like for the third day, it was showing slightly on even higher stage with regard to the reference range. So we advise the patient verbally to consider low potassium for the time being until the potassium level comes back to normal. I didn't mention it in the diet plan. We just verbally counseled.
Okay, okay, good. But it's very nice to see your slide on drug and nutrient interaction. Yeah, very
Thank you.
good.
Christina, thank you so much for the thorough presentation.
Thank you, ma'am.
Yep. Now we have our last presenter for the day. Ms. Annapurna, are you ready?
Yes, ma'am, I'm ready.
Go ahead. Your time starts now. You have 12 minutes.
Yeah. Can I have the slides, please?
Sai, can you please share the slides?
Slides. Slides are not audible. I can't see them.
Yeah, I think it's loading.
Oh, just, okay.
Yeah,
so good evening, everyone. My name is Annapurna Bhatnagar. I'm from Bhopal. I'm a practicing clinical nutritionist and I have my own diet clinic in Bhopal. So today I'm presenting a case where I got in my clinic of a 60-year-old female with recently detected diabetes. Next slide, please. So she was a 68-year-old female Maharashtrian lady who had been recently detected with diabetes. Next slide, please. So she had a history of hypertension since last 10 to 12 years, and her triglycerides levels were 222 when she came to us. Her HbA1c was 8.3. She presented complaints of chronic constipation, low energy. So when we did her history, when she came to our clinic, when we did the RBS, it was 201. Her BP was 145 by 89. During the course of the 1 hour consultation that we did with her, we took a long history of her diet pattern, her emotional health, and all. So her basically full day diet was just a second. Let me put on my camera, please. Yeah. So from morning, she used to take some water with some dry nuts, which included about 10 to 15 pieces of raisins. Then it was followed by a cup of tea with 1 teaspoon of sugar. Then her breakfast was a bowl of mixed fruits, followed by lunch, which was about 2 rotis and sabzi and 1 glass of buttermilk. Evening, she again repeated a tea, and for dinner, it was roti, rice, and dal without any vegetables. She used to have salads occasionally. She had a good history of sleep. There was no issues in sleep, but then she used to wake up at least 2 to 3 times to go to the washroom. Next slide, please. So we had done a BCA test on her, in body BCA, which I have attached the reports in the later slides. So on doing the BCA, what we understood was she had a low skeletal muscle mass, which was 16.2, high body fat percentage. She weighed only 55 kgs at a height of 151 centimeters. So she was not overweight as such. So when we counseled her, what she said was that I don't want to take medicines. I just want to do it with lifestyle intervention and nutrition. So since her HbA1c was very high, we wanted to know whether she had the permission of her treating physician. So we had a talk with the doctor where, since he said that RFT was normal, her renal parameters were normal, EGFR was normal, so we can give a trial period of 3 months to see how she responds to nutrition and lifestyle intervention, and then continue further. So since we had the go ahead from the doctor, we did a BCA where we found all this. She had a low protein intake, which was quite obvious from her diet history. A sedentary lifestyle. She had lost her spouse about 2 years back. So she was very lonely. She was low on energy. She didn't have the energy to do even simple household chores. So, clinical interpretations and key focus areas that we understood was sarcopenia, because she had a lot of very less muscle mass, and glycemic control, because her fasting was ranging between 150 to 160, and she had insulin resistance, gut health because of the constipation and all. So what we made a plan was to improve her muscle mass, reduce the fat percentage, enhance her insulin sensitivity, and correct her gut health. Next slide, please. We knew we had to go very slow with this lady because of a lot of issues, her emotional health, her apprehensions to start something, though she was very determined, and that is why she had come to us. But still, there were initial apprehensions of starting the diet and making lifestyle changes. Since her protein was very low, we focused on giving her initially at least 1 gram per kg body weight, because earlier it was not even that much. Structured meal timings. We asked her to stick to as much as possible to same meal timings every day. Fiber enhancement, of course, since she didn't have much fiber in her diet, we included vegetables and salads in every meal of her. Omega 3, of course, in the form of walnuts and flax seeds and all. We totally cut down on simple sugars, like we cut down on the quantity of raisins that she was taking, and we also cut down sugar from her diet. Portion control was not much an issue because she was not a big eater. But yes, the plate had to be balanced. What we suggested was including vegetables and fiber in every meal. And we also focused on sequencing of her meals. What we started asking her to have the fiber and the protein first, like her vegetables and some sort of dal, paneer, whatever she takes, to have that first, and then go to her rice and roti. So this helped to also control her postprandial glucose levels. As far as lifestyle recommendations are concerned, since she was a very sedentary lifestyle, she never walked, and even after meals and all, she used to just sit. So we first thing focused on 10 to 15 minutes meal after walk after every meal, to improve her glucose absorption and also digestion. Resistance training was started after a period of about a couple of months, because we wanted to get her used to the fact of that she has to do some kind of activity. Daily walking was incorporated right from day one itself. We asked her to do some walk in the mornings and evenings, other than 10 to 15 minutes walk after meals. Hydration was corrected. She was very low on hydration. She complained like, I don't feel like drinking water. So we asked her to do some infusions in her water, like cucumber, mint, even cinnamon, to help her deal with the hydration levels. Also, when we changed her diet, since we removed the fruits from her breakfast, we started giving it in the mid morning as a mid morning snack, along with some nuts and seeds, so that the glucose absorption is slower, and also with a pinch of cinnamon powder. Constipation was managed since we started focusing on fiber and all. Within a period of 10-12 days, her constipation was much better. Next slide, please. So this is what we understood from 6 months of metabolic treatment. First, what happened was after 3 months, her HbA1c came down from 8.3 to 7.5. So we again had a consult with the doctor. Since the HbA1c had come down, and point to be noted is because of her high triglycerides, she was also on statins, and that is why also the doctor said since she's already on statins for high triglycerides and there is no other organ involvement, she can continue for the first 3 months on dietary intervention. So after 3 months, when her HbA1c came down to 7.5, we again had a talk with the doctor. So again he said, okay, we can try further because her HbA1c is already come down. So this is after 6 months. Her HbA1c came down to 6. Her constipation was totally resolved. Triglycerides after 3 months came down to 190. We don't have the report for the 6 months because since she was on statins and her triglycerides had come below 200, the doctor said right now there's no need to do a lipid profile. So we only repeated the HbA1c. Her energy levels were improved, and since she was also lonely because of the loss of her spouse, we encouraged her to go out, meet her friends, or go into the society and do some walks. So that also helped her to be more social and also improved her energy levels. She was much better after a period of 3-4 months. The body composition, what we saw, 43.5 to 41.6 of fat percentage. Muscle mass increased from 6.2 to 16.2 to 16.1. Though it's marginal for a 6 months, we also have to consider her age and the emotional condition that she came into. But yes, she was very determined and very consistent in what she did. What basically helped also was our regular follow-ups. We kept following up with her. Regular monitoring was done. Since her daughter stayed nearby, we encouraged her daughter to visit her more often and also make sure that she exercises and she walks and she also does her routine very consistently. Next slide, please. So this is basically the clinical insights that we understood. We all know that muscle mass and glycemic control, improvement in muscle mass was a very big factor in getting her glycemic control. Skeletal muscle mass, primary site for glucose uptake. Protein optimization, since she was very low on protein, and since we are going to cut down on simple carbs, and also we made her have protein of 1.5 and 1.1 gram per kg body weight, and later on we intend to increase it to 1.2 gram per kg body weight. Lifestyle intervention, of course, in early stage diabetes, but again we only did this when we had the go ahead of the doctor, because it becomes very important that at 8.3 we cannot decide that we have to go it only by lifestyle and nutritional intervention. We also increased her calcium sources, because we all know at the age of 68 her bones may be brittle, so we added sesame seeds, ragi in her diet. Next slide, please. Again, beyond medication, this is what helped: personalized nutrition, and we try to make it as sustainable as possible, and that is why she is still with us and continuing the program with us. Targeted exercise, we had to be very careful with her exercise routine, because initially she was very reluctant. We started by simple walking, and later we asked her to buy a resistant band and do some simple exercises at home. Consistent monitoring through follow-ups and regular clinic visits were done to motivate her, encourage her, and also to make her more disciplined in this case. Next, please. So this is basically what a holistic approach and interdisciplinary collaboration looks like: a primary care physician, patient support and education, dietitian, and a regular exercise trainer. We even had to counsel the family members of her, because like I said, she was very lonely, and she had two daughters, one daughter staying outside and one with her who used to stay close by. So like we encourage the daughter to meet her more often or call her to her place, so that she has a support from her family members. Next slide, please. So the key takeaways for this clinical practice is to prioritize lifestyle first. But again, it differs from case to case. Assess body composition. These days, weight, only the numbers on the scale is not everything. We have to know how much is the muscle mass, fat percentage, visceral fat, which helps us to identify sarcopenia, especially in elderly cases. Emphasize protein intake, of course, integrate resistance training. Diet will only work in this case without medications if we incorporate the right kind of exercises. Holistic patient care, we made sure that her emotional health were also improved throughout this time. Next slide, please. Again, age is not a barrier. This can be done at any age, uh, provided the client has the willpower and wants to do it. Next slide, please. So this is her HbA1c. When she came to us, it was 8.3, and after 6 months, we saw it at 6. So these are the lab reports. Next slide. This is the BCA in-body BCA that we do. So when she came to us, her muscle mass was 16.2, then it came to 16.9. Her body fat percentage was 46, and then it came to 43, and then it came to 41. There were a little ups and downs. Like I said, we had to deal with an elderly geriatric patient. So that was always when she went off track, and so the whole thing about this case was we kept motivating her, we kept encouraging her, and we managed to bring her HbA1c under control. And right now also she's off. She has not started medications, which was fortunate for us. And she's still on hypertensive medicines and for hyperlipidemia, and she continues to be with us, again maintaining her blood sugar levels and for her further body composition. Next slide, please. Thank you so much.
Thank you so much, Ms. Annapurna, for that very unique case study that you have done. Thorough follow-up. Good one. Any questions for Annapurna?
Annapurna, nice presentation.
Thank you, ma'am.
Congratulations.
Thank you.
One question. What is the calorie calculation for this patient?
You what, ma'am?
Calorie
Can
or
I?
macronutrient calculation.
Micronutrients.
Macro.
Macronutrients.
Protein.
Calorie.
Okay. So macronutrients, what we focused on was on 40 calories, 40% of proteins, and the 20% from fat, healthy fats.
What is the progression? Case progression.
Case progression is, like I said, her HbA1c has come down to 6. So her doctor has advised her to maintain it below 6.5. We are still working on reducing her fat percentage further and increasing her muscle mass further. It's going to take time. It's been 6 months, but we have managed the blood parameters to quite some extent. Now we are working on the body composition analysis as she is still with us.
Anyone else have any questions?
Very
Yeah,
good presentation, Annapurna. It looks like a holistic presentation. It's a very good one, and it's a follow-up of 6 months. So
Yes, ma'am.
that's
Thank you.
really very good.
Thank you.
Anyone else? Somebody tried saying something?
Yeah, Annapurna, it was very nice presentation. You have thoroughly mentioned about one is a lifestyle disorder and case, and good
Yes,
to
ma'am.
see that you have chosen the
Yeah.
in body this BWA. This is a very new classifications and new tool because
Yeah.
previously we are doing the DEXA scan and other things, which is a bit costly. But in bodies, it's something what I am also using in my hospital that we can see the changes of the result and most directly about the
Yeah.
sarcopenia and also the body fluid composition, intracellular, extracellular fluid compositions that you can good to see that what about the therapeutic diet would helpful for these particular things, because nowadays not only the BMI but also the
Yes.
other things about the muscle, about the fluid are simultaneously important that you have thoroughly mentioned in this case presentation.
Yes. Yes.
And that is very true. But simultaneously, that I haven't seen any kind of drug nutrient interactions in your slide, where we have mentions about the one particularly statin is going on for the cholesterol lowering. So it could
Yeah.
be much more effective, being a clinical dietitian, if you can mention about the drug nutrient interaction for your cases, particularly what is the food and what is the drug is giving on, and what could be the retributions and what could be the intra management about the drug nutrient. Though you have mentioned about the holistic approaches, but a teamwork about the multidisciplinary approach for a clinical dietitian, physician, physiotherapist, and other healthcare professionals. So it could be, if it could be better if the drug nutrient part would be there in your slides.
Yeah.
Otherwise, it's excellent presentation.
Thank you, sir. Thank you. Actually, since first of all, she was not on metformin, and which usually we have B12 deficiency. But since she was a vegetarian and a geriatric lady, her B12 and vitamin D were always already on the lower side, for which she was taking supplements. Baki remaining, we tried to compensate through the diet which we had, and like I said, we took it very slow with her, and we tried to manage as much as possible. And for rest micronutrients, we again, like for selenium and all, we gave her Brazil nuts. For calcium, I tried to increase. So we have taken care of all the other micronutrients as much as possible.
Right, excellent.
Thank you, sir.
Thank you, Ms. Annapurna.
Thank you, ma'am.
And yep, that concludes our presentations for today. Again, congratulations to all the presenters from today's webinar. Jury members are going to submit their evaluations, and based on that, we will pick a winner for today, and we will announce it very soon on our social media. Thank you, jury members, for being with us today and sparing your time. And thank you, participants, for joining us and encouraging the presenters. And that concludes our case study contest for February. Thanks, everybody.
Thank you, Wasing and Dipti, and thank you, Pals, for a nice and empirical competitions. And thank you for choosing me over here. Thank you.
Our pleasure.
Thank you, Deepti ma'am. Nice meeting you after a long time.
Yes, Reshma. Same here.
Thank you, Deepti.
Yeah, sure, Dr. Rania. Thank you again. I hope to see you all again very soon.
Okay, sure. Bye.
Bye bye.